Thanks for joining us. My name is Adam Leventhal. I am director of the University of Southern California Institute for Addiction Science. This is our speaker series that you're joining us for. And before I introduce Dr. Montes, let me just tell you a little bit about our institute for those who may not know about us. We are sponsored by the Keck School of Medicine, the Suzanne Dvorak Peck School of Social Work, the USC School of Pharmacy, the Norris Comprehensive Cancer Center, and the USC Department of Preventive Medicine. And the reason I mention all those sponsors is to illustrate kind of the interdisciplinary nature of our institute. So our goal is to promote transdisciplinary addiction research, education, and community engagement. And we really are excited to bring disciplines together. And today we have an outstanding speaker who happens to be in the same discipline as myself, Dr. Kevin Montes, who is a clinical psychologist. A little bit about Dr. Montes. He is currently an assistant professor at the California State University Dominguez Hills campus, just on the other side of Los Angeles. His research focuses on understanding the role of drinking and recovery identity and how that plays into use behavior and recovery, and how individuals engage in harm reduction when using substances. And I'm looking forward to his talk, which will address some of these key questions. Dr. Montes strives to examine predictors and mechanisms of substance use across a bunch of different substance use domains. So he's known a lot for his research in alcohol, but he's also done some great work in the area of cannabis and tobacco product use, and interesting work across the lifespan. And I had the pleasure of collaborating with Dr. Montes on a great paper on developmental trajectories of youth beliefs about substances and their role in substance use risk. Dr. Montes is currently supported by a National Institute of Health grant to examine identity change as a mechanism of behavior change in alcohol recovery. So before I toss it over to Dr. Montes, housekeeping, if you have questions, you can enter them right into the chat if you'd like. We'll hold all questions during our Q&A period, which will be right at the end of Dr. Montes's presentation. And at that time, you can either ask your questions live or enter them in the chat. So without further ado, Dr. Kevin Montes.
Thank you, Adam. Thank you for that wonderful introduction. I really appreciate it. And it's such an honor to be here and be part of this distinguished speaker series. So again, thank you so much for giving me an opportunity to be here today. I really, really appreciate it. So let me go ahead and just share my screen. Just go ahead and move that. And this, okay. Yeah, thank you again. Thank you so much for inviting me here. Thank you for that wonderful introduction. I also like to just note, I was interested in being a clinical psychologist, but I'm actually an experimental psychologist, and I'm kind of getting into the clinical psychological domain, and so I do a little bit of that, but my expertise is mainly in experimental psychology. Thank you so much again for being here. So today I'm going to talk about some of the research that I conducted over the past 5 years that's focused on the examination of predictors of substance use, approaches to harm reduction and alcohol recovery. I'm an assistant professor at Cal State University Dominguez Hills, and I also like to note that I'm an alumnus as well of Cal State University Dominguez Hills. So it's kind of nice to be come back full circle, to be back in SoCal. It's really a pleasure, and to work with CSUGH students, it's truly an honor. In terms of before developing this talk, I wanted to segue right into my research, but then I was wondering, maybe it's important to provide some context as to why should we focus on substance use? Why is that important, right? Like, why should we care? So this is some data from the Global Burden of Disease study, looking at risk factors by number of deaths. And as you can see, smoking, drug use, alcohol use represent top 15 risk factors by number of deaths. And this is in the United States, right? So, substance use is associated with, is essentially a mortality related risk factor. So it's important to obviously investigate substance use and conduct research in this area, right? And what about with the families? Why should families care? Well, this is some data from a Gallup poll that was conducted with 1,000 adults. And across the board, we can see between 23 and 39% individuals say, yes, drinking or drug abuse has been a cause of trouble in one's family, right? So it doesn't matter if you're male, female, have a college degree or don't have a college degree, you go to church or you don't. Substance misuse can have a negative impact within the family. And so I think it's also important to note that even if one does not use marijuana, alcohol, tobacco, or other drugs, watching other family members use substances can be quite difficult. And in terms of the prevalence rates of lifetime substance use, so this is some data from Monitoring the Future between 2017 to 2020. And this is just, basically rates of lifetime substance use among 8th graders who said, yes, I have used, for example, alcohol or cigarettes or marijuana or vaping. And as you can see, the general trend is that, more 8th graders, for the most part, are saying that they have used, for example, alcohol. We see an increase in use among 8th graders for alcohol, cigarettes. To a certain extent, we see a general trend with marijuana and then also vaping marijuana as well. So we see that individuals and specifically adolescents are using substances or starting to use substances at a younger and younger age, right? So that's also problematic. So for all of these reasons are definitely important to conduct research in this domain, in this area of substance use. Personally, my first foray into kind of the addiction research area was as a grad student, I was interested in actually gambling. And the reason why I was interested in gambling and kind of behavioral addictions was, going to the casino and seeing that, one individual could go ahead and gamble and go home and experience relatively few problems or no problems whatsoever. And the individual next to them would go and experience significant problems, maybe go back to the ATM and take out more money. And so it was very interesting that certain people can engage in similar behaviors and experience different outcomes. So personally, that's why I kind of got into the gambling research space as a graduate student, and then kind of transitioned to focus more on alcohol and alcohol research as a postdoc, and then currently now kind of focusing on behavioral addiction, but mostly kind of alcohol use and problems associated with alcohol use now as an assistant professor at CSUGH. So today I'm going to talk about predictors of substance use, focusing on alcohol expectancies, as Dr. Leventhal noted, our paper. So I'm going to talk a little bit about that. I'm also going to talk about how substance use identity is related to outcomes and frequency, quantity, consequences, and disorder symptoms. I'm also going to focus on harm reduction, talk about PBS a little bit, and about the efficacy of a parent-based intervention that it was a part of conducting in 2015, 2016. And then I'm going to talk a little bit about alcohol recovery, talk about definition refinement, and the role of identity change. So first, I want to talk about the paper that Dr. Leventhal and I are on, that's really looking at expectancies and changes in expectancies as predictors of substance use initiation in adolescence. So you might be asking, what are substance use expectancies? So substance use expectancies are beliefs regarding the perceived positive, negative, behavioral, cognitive, and emotional effects associated with substance use. As you can see up here, kind of there's this kind of alcohol goes in, fun comes out, right? So essentially in a nutshell, what alcohol kind of positive expectancies are includes like, hey, that you're, more social when you drink, or, if you drink alcohol, you're going to experience some like tension reduction. And some of the negative consequences or expectancies associated with alcohol use include being clumsy or dizzy or self-critical. With tobacco, some of the positive expectancies include, that it's going to reduce your stress or be energizing or help you stay fit. And in terms of the negative, tobacco expectancies include potentially, getting cancer or the smell of tobacco as well might be kind of a turnoff. And then with marijuana, it's again, kind of a stress reduction fun, right? And then with negative consequence or negative expectancies includes like harm or hard to remember or hard to concentrate. So these expectancies essentially guide potential substance use. The more positive expectancies you expect versus negative kind of expectancies, there's kind of typically an increased likelihood or chance of using or engaging in substance use. So expectancies in the literature have been found to be predictive of substance use, and most notably, higher positive substance use expectancies are associated with greater risk of lifetime use. And really, this is kind of the novel piece of this research, is looking at change in substance use expectancy. So looking at change in positive and change in negative substance use expectancies, and basically seeing if that change is predictive of substance use onset, and really looking at a group of adolescents that reported never using before, right? So we're looking at pre-onset expectancies, alcohol, tobacco, marijuana as predictors of substance use onset in mid to late adolescence. So I'd like to thank Dr. Leventhal for graciously allowing us to analyze the data from his study on happiness and health. The data come from 10 high schools in LA. Overall, there are about 3,300 participants. And in terms of the data analytics size, so we were looking at 1,700 individuals as of 10th grade who never reported using alcohol, approximately 2,600 reported never using tobacco as of 10th grade, and then 2,300 reported never using marijuana as of 10th grade. On average, they were about 14 years of age, 47% were Hispanic or Latino. And in terms of assessing positive expectancies, participants were asked, I think I might enjoy, experience pleasure, or feel good using alcohol, cigarettes, or marijuana. In terms of the negative expectancies, I think I might feel bad, sick, or embarrassed using alcohol, cigarettes, or marijuana. In terms of onset, participants were asked, have you ever used a specific substance in the past 6 months? In terms of the design, it was a longitudinal design with 8 ways of assessment, 6 months apart, starting in 9th grade and ending in 12th. And we used lane growth curve modeling specifically to derive parameters, specifically the intercepts and slopes of expectancy trajectories between waves 1 through 4. So really just looking at how did expectancies change in 9th and 10th grade, and to basically examine the slope and that change as a predictor of substance use onset in 11th or 12th grade. So what did we find? So across the board, we found specifically when we looked at positive expectancies, that positive expectancies were positively associated with, for example, alcohol onset. So for positive alcohol expectancies, for alcohol onset, for positive tobacco expectancies was predictive of tobacco onset, and then positive marijuana expectancies were predictive of marijuana onset. So specifically pre-onset positive alcohol expectancies, that slope was predictive of an increased likelihood of initiating alcohol use for the first time in 11th or 12th grade. And we found similar trends when we looked at tobacco and marijuana. So our hypotheses were supported, which is awesome. It was definitely great to see. So changes in pre-onset positive expectancies were found to be predictive of adolescent substance use onset, which was great. There's also this negative association between negative marijuana expectancies and onset. So for example, for participants who believed that maybe marijuana wasn't as bad as they thought it was going to be, and we saw kind of reductions in those marijuana expectancies, that reduction in negative marijuana expectancies was predictive of an increased likelihood of using marijuana for the first time in 11th and 12th grade. In terms of future directions, additional research is needed to elucidate the extent that family history, social networks, and social media are associated with changes in pre-onset expectancies. And identifying proximal antecedents of pre-onset expectancy change could be helpful in augmenting current prevention and intervention efforts that attempt to discourage adolescents to initiate substance use. So now kind of transitioning away from expectancies and focusing more on substance use or identity, which is kind of the area that I'm currently focused on. Really had this awesome opportunity to work with Dr. Matthew Pearson on this meta-analysis. This is the first time for me conducting a meta-analysis, and it wouldn't have been possible without Dr. Pearson. So I'm going to talk a little bit about that. So you might be asking, what is substance user identity? Well, it's the extent to which individuals identify as being a substance user. So for example, you ask, what extent do you identify as a drinker? Or to what extent do you think that drinking is an important part of who you are as a person, right? So really just getting at, people and individuals, do they identify as a drinker or as a marijuana user or a tobacco user? Why does that matter? Why does identification matter? Well, there's theories such as the social identity model of cessation maintenance, the social identity model of recovery, prime theory of motivation, and theory of planned behavior, all have implicated identity and its role in substance use and addiction, right? So there's theoretical support for looking at identity and its impact on substance use. Substance user identity has been examined in previous studies and found to be predictive of the frequency, quantity, and consequences and disorder symptoms. So we kind of see that in the literature. Really importantly too, that when we look, for example, in the drinking literature, we do see variability in the strength of that identity outcome association across studies. And there's also likely similar variability in that association in other substance use domains such as tobacco and marijuana. And for the most part, drinking identity has been looked at and examined within the drinking literature and to a lesser extent in the tobacco or marijuana literature, but there still also might be that variability. and that effect within those other substance use domains. So what do we need? So why conduct a meta-analysis? Well, it'd be really nice to have a single kind of, or nice to have these single weighted estimates of these associations to more precisely characterize the magnitude of effects across various substance use domains. Examining variability in this kind of identity outcome association could lead to the examination of moderators and mediators of these associations. And also too, meta-analytic findings, in addition to kind of review articles, are really helpful in helping researchers new to the construct of substance user identity become more well acquainted with this research area. And so what did we do? So the study aimed to meta-analytically derive precise weighted estimates of the association between substance user identity and substance use related outcomes. And the outcomes we were specifically focused on were kind of this frequency, quantity, consequences, and disorder symptoms. You might see the kind of Lord of the Rings ring up here. It's kind of like, one ring to rule them all, kind of like one effect size to rule them all in a way, kind of, to spice up, this meta-analysis and the findings. We also examined moderators of the identity outcome association. So we're looking at substance type, measurement type, substance related outcomes, demographic characteristics, and research design as kind of moderators of that identity outcome association. So what did we do? We used PsycInfo and PubMed on February 8th in 2019 to kind of find all the articles that we needed to conduct the meta-analysis. We were specifically looking at articles that had a correlation coefficient or odds ratio. The inclusion criteria included any kind of peer-reviewed article published in English that reported effect sizes. We're looking at quantifiable, any kind of paper that had kind of any quantifiable assessment of substance user identity and included one of the 4 outcomes: frequency, quantity, consequences / problems, or disordered symptoms. And we also reached out to some authors as well. Overall, the meta-analysis included 70 articles or studies, 43 alcohol studies, 24 tobacco, and 3 cannabis. So what did we find? So overall, when we look at the relationship overall between just substance user identity collapsing across all substance and outcomes, again, collapsing across all outcomes, we found that the relationship between substance user identity outcomes is about 0.365 in terms of that kind of weighted correlation coefficient. When we look at it across substance use domains, we see that there's a stronger identity outcome association across the 3 studies, the 3 cannabis studies, and then tobacco is about 0.40, and then alcohol drinking about 0.337 or 0.34. In terms of looking at the identity outcome association, when we looked at it explicit versus implicit, so implicit, kind of like the implicit association test would be a good example of these kind of implicit measures. We do see that the identity outcome, relationship is stronger when explicit measures versus implicit measures are used. And then also within this kind of alcohol domain, we were looking at outcomes. The strongest identity outcome association was found when identity was kind of associated with disordered symptoms at 0.370. So we have essentially this moderate to large overall association between substance user identity and substance use related outcomes. So about 0.365. So kind of again, this moderate to large overall association, which essentially substance user identity explained about 13.3% of the variance in substance use related outcomes. What about moderators, right? So we looked at substance type as a moderator, the identity outcome association. We didn't find substance type as a moderator, but we did with measurement type. So when we looked at explicit versus implicit, we did see a stronger identity outcome association when we looked at explicit measures, right? Part of that might be attributed to the fact that the implicit measures generally have lower levels of reliability. So when we applied an attenuation correction formula to kind of control for that, the differences in reliability, the difference between explicit and implicit measures in terms of the identity outcome association was smaller. So just wanted to make a note of that. When we looked at substance related outcomes as a moderator, it wasn't a moderator, but when we looked at demographic characteristics, age was a statistically significant moderator, and specifically there was a stronger identity outcome association among younger individuals. So it could be that younger individuals kind of use substances in a way that conveys important identity-related information, maybe to a greater extent than older individuals. When we looked at research design as a moderator, we didn't find research design as a moderator of the identity outcome association. Some clinical implications. So I think it's important to look at studies where the identity outcome association is particularly strong. So if we look at studies where that relationship is particularly strong, We can potentially look at and identify some risk factors. Do we see, within that sample, is it there are differences in social network? Is it college student status? Maybe they're college students or geographic region. So for example, being in Miami versus Grand Forks, right? Is there, what potentially are some risk factors that may lend themselves to this stronger identity outcome association? Conversely, we could also look at studies where the identity outcome association is particularly weak. So looking at, they might be protective factors. So again, social support or relationship status or religious affiliation might be associated with why there's kind of a weaker identity outcome association in a particular sample. In terms of future directions, additional research on smoking and marijuana identity are needed. So overall, substance user identity is an important correlate of substance use and misuse. All right, so kind of segueing a little bit, and still focusing on the identity outcome association. So in that meta-analysis, we're focusing on really kind of narrowing in on that kind of that weighted correlation coefficients, right? And try to like average and summarize those effects. This study really focused on looking at mediators as opposed to moderators of the identity outcome association, and in particular looking at alcohol and marijuana PBS as mediators of the relationship between substance use identity and use-related outcomes. So again, you might be asking, like with expectancies, what are PBS? What are protective behavioral strategies? Well, PBS are cognitive behavioral strategies that are used to minimize the harmful consequences associated with substance use. Here are some good examples based on the PBSS, which is Martin scale. So for example, we have limiting and stopping drinking includes leaving the bar or party early, or use drinking water. Manner of drinking includes avoiding shots or avoiding drinking games or trying not to keep up. And for serious harm reduction includes, finding a designated driver or going home with friends. What about marijuana PBS? So some PBS strategies related to marijuana use include using marijuana only among trusted friends, limiting use to weekends, only use one time during the day or night, or avoid mixing marijuana with other drugs. Okay, so that's essentially in a nutshell what PBS are. As we observed based on the meta-analysis, there was this moderate to large association between substance user identity and substance use. And again, our meta-analysis really focused on moderators of the identity outcome association, where the current study is focused on kind of mediators of that association, looking at PBS. And again, identifying mediators may help shed light on the mechanisms or processes that underlie the identity outcome relationship. So what did we hypothesize? So we examined PBS as a mediator of the relationship between drinking and marijuana identity and alcohol and marijuana related outcomes. Specifically, the outcomes we're focused on were frequency, quantity, and consequences, via secondary analysis of 3 separate data sets. And specifically what we hypothesized was that individuals with this kind of higher level of substance user identity would report using fewer protective behavioral strategies, and the use of fewer protective behavioral strategies would be associated with the reporting of kind of or engagement in more frequency, quantity, and consequences associated with alcohol or marijuana use. So in terms of the 3 data sets, so the first data set we looked at were essentially this data set with some heavy drinking college students. The second data set we looked at was from this multi-site study that included marijuana users. And the third data set included alcohol and marijuana users as well. Within a community sample, we conducted the study via MTurk. Overall, in terms of the college student samples, they're about 19 to 20 years of age, 19 to 21. In the community sample, they're in their early 30s. Participants were predominantly white, and across the board, substance user identity was basically examined using this 5-item smoking self-concept scale that was adapted for alcohol and marijuana use, and specifically looking at alcohol and marijuana identity. In terms of the PBS measures, the 15-item PBSS was used, and the 17-item PBSM was used. Frequency and quantity of substance use is also requested. And then in terms of alcohol and marijuana consequences, the 23-item RAPI was used. And then for marijuana consequences, the 21-item BMAC was used. For data sets 2 through 3, there was a cross-sectional component. And for data set 1, there was this longitudinal component as well. We conducted mediation analyses in M+ and age and gender service covariates. So what did we find? So looking just right now just at alcohol, with respect to alcohol, mediation findings were limited to manner of drinking PBS. So this is the PBS that are associated with, for example, avoiding drinking games or avoiding taking shots of alcohol, right? So we found that manner of drinking PBS was a mediator of the relationship between 2 of the 3 alcohol-related outcomes. So it wasn't a mediator of the relationship between identity and frequency, but it was a mediator of the relationship between identity and quantity and consequences. And in terms of the A and B path, the direction of the effects were in the hypothesized direction. So what we found is that individuals who had higher levels of substance user identity were less likely or used fewer manner drinking PBS, and the use of fewer manner drinking PBS was associated with the reporting of kind of more alcohol quantity and consequences. However, there was limited support for these mediation effects longitudinally. But we did find again that the direction of the effects were kind of in the hypothesized direction, which was good. In terms of marijuana, marijuana PBS were found to mediate the relationship between marijuana identity and all three marijuana-related outcomes evaluated. So again, we were able to kind of see these effects, not just in the looking at alcohol, but also looking at marijuana. And so marijuana PBS mediated the relationship between marijuana identity and frequency, quantity, and consequences only in the second data set. Overall, these findings represent an important scientific contribution to the existing substance use identity and PBS literature because they support the existence of a relationship between identity and PBS. Looking at the literature, there's limited kind of knowledge in this area. So really finding this relationship between identity and PBS was important. The identity PBS relationship could be targeted in prevention and intervention work. So for example, trying to decrease individuals' identification as a drinker, a marijuana user, or try to increase their PBS use, maybe MOD PBS or marijuana PBS could help tackle and help reduce kind of outcomes, for example, frequency, quantity, and consequences potentially. All right, so now want to segue into this this one study that I had the opportunity to work on once I graduated from the University of North Dakota. So I was doing some gambling research, and I had this opportunity to work on this R21 that Dr. Joe Labrie was able to get funding for, to really look at a parent-based intervention that reduces heavy episodic drinking among first-year college students. So this is kind of my first foray into the alcohol research domain. So why conduct this kind of parent-based intervention? So college drinking is associated with an array of negative consequences, and we all kind of know that, right? Parents' attitudes exert influence on their college-age children's drinking behavior. So, this isn't a picture of me when I was 3 or 4, but this is, it's just a meme that I was able to find. But this is what I believed when I first got into the lab, because I was doing a lot of gambling research, didn't really know much about parent-based interventions or alcohol research at this point. And I thought, when the parents are away, the children will play, right? So I was like, to what extent really do parents influence their college-age children's drinking behavior? Well, actually, there's a ton of research to suggest that that is the case, right? So, now definitely after this intervention and being part of this intervention, I am a believer. So parents hold misperceptions that may influence their thoughts and behaviors regarding their child's alcohol use. And I'm going to talk a little bit about those parent misperceptions on the next slide. And social norms interventions have been found to be effective at reducing students' normative perceptions and drinking behavior. So social norms interventions may in turn be equally effective at reducing parents' misperceptions. So you might be asking yourself, what kind of misperceptions do parents hold? So based on some previous data that was collected at LMU with parents of LMU kind of students, parents were found to misperceive some of these essentially parents were found to misperceive or hold certain misperceptions. So for example, when parents were asked, how many drinks per week will your son consume in college, right? So if you imagine you have a son, they're going to college, you'd probably think, oh, my son, Johnny, they're not going to drink. I know him, he's a good boy, he's not going to drink. So parents tend to underestimate how much their son is going to drink once they're in college. Parents are also found to underestimate or also found to misperceive this too. So how many drinks per week does a typical LMU parent think it is acceptable for their son to consume? So they think that most parents are really permissive, that other parents are going to allow their sons to consume a ton of alcohol, right? But their son, obviously they're saying, yeah, my son Johnny's not going to really, consume, but other parents are okay with their sons, drinking a lot. What about this? What percentage of LMU parents have spoken to their son about alcohol use in the past 3 months? So they're going to say, hey, we talk to our son Johnny a lot, but the typical parent doesn't. And so they're going to underestimate how much other parents talk to their son or daughter about alcohol use, right? So we did find that parents misperceive, right? They hold misperceptions, and these misperceptions could impact the extent to which their son or daughter uses alcohol once they're in college. So this is kind of a graphic that was used during the parent intervention. And so just imagine a ton of parents, there was parents of male students and parents of female students, and they're in different sessions. So this is just for the parents of male students. But they were shown, this graphic. And so this is the part right here where parents' data was basically displayed. And these norms were already present. We already knew what they were. And so these were already kind of imposed on on the slide, right? And so these norms were based on data that were collected at LMU. So for all men, so just overall for men, male college students at LMU, on average, they drink about 10 drinks per week, which is, again, pretty similar to other universities as well in terms of their drinking behavior. And then men who drink, so just focusing on men who drink, it's about 14. And again, we wanted to kind of find this misperception, and this was really important. So again, when we asked parents, for the most part, how many drinks per week will your son consume in college, we assumed that we see this positive skew, that most would say, oh, my son Johnny would drink 0, 1, or 2. And then we would have these actual normative, kind of essentially component right here of like, no, based on data that we've collected, we found that they actually drink 10 to 14. And there was this large misperception. And honestly, when we presented this slide, parents did laugh, right? And we're not saying that, you don't, we were saying like, we don't, obviously you may know your son or daughter better than we do, but, overall in the aggregate form, there's misperceptions, like something's going on in terms of, there's this discrepancy between what parents think is going to happen versus what actually happens in college. So after parents were presented with their own normative misperceptions, it was kind of posited that they would be more amenable to tips, right, and strategies on how to better interact with their child about their alcohol use. Some of those tips included how to start a conversation. So, for example, don't ask, your son or daughter directly how much they use, but basically ask open-ended questions. We also mentioned the importance of projecting a less permissive attitude towards their son or daughter's alcohol use, and also using hypothetical scenarios. So for example, what if your friend pressures you to drink, what would you do, right? So based on the intervention, we forwarded a number of hypotheses. So for example, we hypothesized that students whose parents were in the Fit Start intervention would drink less and engage in less heavy episodic drinking than students in the control condition. And in terms of mechanism or mediators of that intervention effect, we hypothesized that students of parents in the intervention, that those parents would basically communicate more frequently with their son or their daughter, right? So we posited that there would be this increased level of frequency of communication about alcohol with their son or daughter. And we also hypothesized that students whose parents attended the intervention, that the students' perceptions of parental approval would change, that they would perceive their parents, because they attended that intervention, that they would be less approving. And therefore that would kind of reduce alcohol use and also reduce engagement in heavy episodic drinking. A little bit about the methodology. So this Fit Start intervention was conducted during freshman orientation. There were 6 sessions, 3 for parents of male students, 3 for parents of female students, and it was about 60 minutes long. Parents not in the intervention who were in the control condition attended an IT session. Data were collected at baseline and 1 month post-matriculation. Overall, there were 331 student participants. 137 were students whose parents were received the Fit Start intervention, and then 194 were in the control condition. The majority of the participants were female, 18 years of age, and white. So what did we find? So we did find an intervention effect. So students whose parents were in the intervention were found to drink less than students in the control. So we did find that that was the case. Specifically, students whose parents attended or were in the intervention consumed 3.14 drinks per week versus students whose parents were in the control who consumed 4.53, and that difference was statistically significant. So you might be asking, what was the mechanism, responsible for that intervention effect? So we looked at parents' frequency of communication. That wasn't found to be a mediator. So we didn't see any change in terms of the frequency of communication between parents and their college-age children, right? But we did see an intervention or a mediator. We did see basically that the perceptions of parental approval was a mediator of the intervention effect. So specifically, students whose parents were in the intervention, students perceive their parents as being less approving of how much they consume alcohol once they're in college. Therefore, the intervention indirectly fostered reduction in student drinking by decreasing the number of drinks students perceived their parents to find acceptable. Also, really important, how did the intervention affect individuals or students who reported never using at baseline, or individuals who reported, or students who reported using at baseline, right? So we did find intervention effects for both of those groups. So among those students who reported never using alcohol at the baseline, If their parents attended the intervention, they were less likely to initiate alcohol use during the first month in college. So the intervention did have an effect in terms of delaying alcohol use onset among non-users in college, which is great. And then also another intervention effect looking at heavy episodic drinkers or heavy episodic drinking and consequences among high school drinkers. So focusing on high school drinkers. So if high school drinkers, if their parents attended the intervention, they were less likely to engage in heavy episodic drinking and also experiencing fewer or severe kind of consequences than students of parents in the control during the first month in college. So the intervention did have an effect as well on heavy episodic drinking and consequences. So taken together, the interactive normative feedback with parents coupled with strategies on how to communicate effectively with students about drinking was associated with reductions in student alcohol consumption 1 month after entering college. In terms of the mechanism or the mediator, students' perceptions of their parents' approval of drinking mediated the weekly drinking intervention effect. And the current PBI intervention also reduced the likelihood of students initiating alcohol use and really importantly, engaging in heavy episodic drinking because past PBIs were unable to kind of find this intervention effect for heavy episodic drinking, which is great to see. The intervention, there was short-term efficacy, but not long-term efficacy. And in terms of future directions, that group at Heads Up, they're doing a wonderful job over there. They got some additional grant funding to do this Fit Start Plus and basically to adapt this parent Fit Start intervention and create an online version to increase disseminability of that intervention. So now, again, segueing a little bit into talking about what is recovery. Again, I'm an experimental psychologist and, really just fortunate to have an opportunity to work with Dr. Katie Wickowitz, who's also my KO1 lead mentor, primary mentor, on this concept of really reconceptualizing, really thinking about critically about this concept of recovery and specifically alcohol recovery. So it was just, again, a pleasure to have an opportunity to work with her and the other co-authors on this paper. In terms of what we did, we conducted a narrative review of studies on recovery with a focus on recovery from an alcohol use disorder. I always have to remind myself of what that really represents. What is an alcohol use disorder based on DSM-5? So essentially, an alcohol use disorder is meeting 2 or more symptoms in the past 12 months based on DSM-5 criteria. There's these 4 symptom clusters. And so here are the 11 symptoms. So includes tolerance, drinking longer or larger amounts than intended, time spent in activities related to alcohol or failure to fulfill role obligations. So meeting 2 or more of these symptoms in the past 12 months, an individual would likely be diagnosed with a alcohol use disorder, right? According to the DSM, they kind of identify, what is remission from an alcohol use disorder. Early remission is defined as kind of greater than 3 months, but less than 12 months of endorsing no symptoms of AUD with the exception of cravings. And sustained remission is defined as 12 months or more of endorsing no symptoms of AUD with the exception of cravings. And again, here's this kind of remission rock. So remission is a wonderful thing. But how did we get here? So the early take on recovery was focused on recovery was synonymous with abstinence. So in order to be in recovery, you have to abstain completely, right, based on the temperance movement. However, the Sobel's clinical research documented that treated patients actually demonstrated controlled drinking outcomes. So, engaging in some drinking is possible, right, and is somewhat okay. Low-risk drinking is now well established as a favorable outcome among persons previously diagnosed with an alcohol use disorder. So this is great news. So we moved solely from an abstinence-based conceptualization of recovery to the inclusion of low-risk drinking as an indicator of alcohol recovery. However, little attention has been paid until recently on well-being and functioning, which are also important outcomes that are central to recovery. So really focusing on, well-being and functioning, which haven't received a ton of attention until recently. So based on our critical review, definitions of recovery that rely solely on abstinence from alcohol or the absence of AUD symptoms often fail to consider changes in other outcomes such as improved functioning and purpose in life. So for example, moving from being unemployed to being employed or improvements in mental health, right? And purpose in life, feel like having, purpose in life, as a researcher based on vocation or taking care of one's family members or other things that bring meaning to one's life. Like these are also important outcomes that are associated with, with recovery. Such definitions, so previous definitions that fail to capture the different pathways to recovery that are evident among individuals in the general population. So these kind of previous definitions essentially fail to kind of capture the different pathways. There's different ways that individuals can recover. And that's kind of evident in the general population and clinical population. And Dr. Wikowitz has done, again, a fabulous job of identifying, different groups of individuals, for example, high functioning, heavy drinkers who are able to kind of maintain their high functioning at 3 years and 10 years post-treatment. So that is possible that there is that group of individuals who are able to kind of achieve those outcomes. So our review supports a definition of recovery that views AUD recovery as an ongoing dynamic process of behavior change characterized by relatively stable improvements of biopsychosocial functioning and purpose in life. And I really just want to focus on this kind of NIAAA roundtable discussion that occurred recently. I really want to focus on just what's in the blue right here, focused on well-being. So there's this kind of, obviously focus in the definition on symptom reduction and also on alcohol consumption. But right here at the very end, they have this bit about well-being, which is really important. So for those experiencing alcohol-related functional impairment and other adverse consequences, recovery is often marked by the fulfillment of basic needs, enhancements in social support and spirituality, and improvements in physical and mental health, quality of life, and other dimensions of well-being. So again, we're just basically saying we need more of a hand wave, right, to kind of psychosocial functioning and improvements in well-being as kind of capturing, individuals' lived experiences with respect to alcohol recovery. And just really quickly, just talking a few slides about my current work, really focused on identity change, looking at identity change, the mechanism of behavior change in alcohol recovery. So I was able to receive K01 funding to explore this research question. So there have been calls to examine mechanisms of change in alcohol recovery. And as I've mentioned before, there's recent efforts to develop identity-based models of alcohol recovery, right? However, there's this need for a more rigorous examination of identity change among treatment and non-treatment seekers for an AUD. And one of the big reasons why I was focused on this kind of concept of identity change is that there was this statistic that I came across that said that only 15 to 20% of individuals with a lifetime alcohol use disorder would seek treatment. So about 80 to 85% of individuals report potentially having a lifetime AUD diagnosis and not seeking treatment, but those individuals do report reductions in their alcohol use, which was, again, I was like, well, how do they do that? So I was really curious about this identity change and as a kind of a mechanism that whether or not you're in treatment or not, that can be leveraged to help an individual kind of reduce their use and kind of engage in this kind of process of recovery. So what I proposed in the grant was to examine drinking and recovery identity change as a mechanism of change in alcohol recovery among treatment and non-treatment seekers. And I really think that this quote by Ralph Waldo Emerson really captures kind of the essence of what I'm looking at. So I quote, the only person you're destined to become is the person you decide to be. All right, so that identity change is important and that individuals can kind of initiate that change. Really focusing on aim 3. So really what I want to see is, what are some of the antecedents or precipitants of drinking or recovery identity change? We're looking at self-efficacy, social norms, and negative affect, and the role that they play in helping individuals kind of initiate this drinking and recovery identity change. And in turn, seeing how that change in drinking and recovery identity is associated with reductions in alcohol use, reductions in alcohol problems, and based on that last review of recovery, improvement in quality of life as well. So taken together, changes in pre-onset expectancies, specifically pre-onset positive expectancies for the most part, were found to be predictive of adolescent substance use onset, which was great to see. There's also this moderate to large association between substance user identity and outcomes based on the meta-analysis that was conducted. Alcohol and marijuana PBS were generally found to be mediators of the identity outcome association, and with alcohol specifically as the manner of drinking, PBS were found to be mediators, generally found to be mediators of the identity outcome association. The parent fit sitter intervention was fairly effective at reducing the number of weekly drinks that individuals consumed. And the mechanism responsible for that potentially was changes in the perception of parental approval. And that intervention did help delay initiation among non-users. And among users, it helped decrease the likelihood of engaging in heavy episodic drinking and the experiencing of severe alcohol-related consequences. In terms of definitions of recovery and alcohol recovery, we forwarded a definition that recovery is an ongoing dynamic process of behavior change characterized by relatively stable improvements in biopsychosocial functioning and purpose in life. And lastly, examining drinking and recovery identity change as a mechanism of change in alcohol recovery among treatment and non-treatment seekers is important. I'd just like to thank a few folks. So at CSUTH, I'd like to just thank Dr. Heather Butler and Mark Carrier for the just continuous support of my research. agenda at CSUGH. I also like to thank Dr. Katie Wickowitz, who's my primary mentor on my K01, just unbelievable, fabulous, that I wouldn't be here today without her help and assistance. I also like to thank my other K01 mentors, Dr. Pearson, Lindgren, and Neighbors. Again, without their help and mentorship, I wouldn't be here today speaking to you all. And I also like to thank Dr. Adam Leventhal for his invitation to come and speak with you here today, and then also for his collaboration with myself and with others on that expectancy paper. Lastly, I just would like to thank the CSUGH students have been just doing an amazing job in my lab, who have found wonderful opportunities in other graduate programs. Really just wonderful to have them in my lab. Sad to see them go, but that's the kind of logical progression, right? With wonderful students, they tend to leave and go and do some wonderful things. And that is it. Thank you all very much.
Wow, Kevin, thank you for the excellent talk by an experimental psychologist who's, but you do your work has so clinically relevant. I thought you were a clinical psychologist, but
yeah.
But
I wanted to be. I wanted to be too. That's.
Oh, really?
I mean, it's, yeah. It was like one of those things. It's like clinical or experimental. It was kind of like a coin toss in a way. But yeah, I mean, I do feel like yeah.
It seems like what you chose worked out for you.
Yeah. Yeah. Exactly.
Obviously. Yeah. Well. Okay. Well, thank you for a great talk. And so attendees, feel free. You can either try to raise your hand, and we'll figure out how to unmute you, and which we can do. And it kind of makes it fun. Or you can put stuff in the chat. So either way is fine. I believe that we do have a question from Brian Morris. Thank you, Brian, for your question. So the question is, I'll read it for verbatim. There's a school of thought out there that goes like this, quote, "A person is in recovery if they say they are," unquote. As someone in recovery myself, I get it. And as a recovery coach, I encourage it. Good work, guys. Thanks for sharing.
Awesome.
Yeah. So how would you kind of react to that? So basically, you are what you say you are. If you say you're in recovery, you're in recovery. Kind of, what do you think about that? Because you're doing, there's very few people actually scientizing that. Yeah. Right? Because we know from clinical settings and 12-step programs that like these are really important concepts. They just haven't received a lot of empirical attention. So what would you say, in this kind of domain, Kevin?
Yeah, no, I mean, it's interesting. I think, from an empirical basis, you're absolutely right. Like, it's not a lot of people are kind of tackling that question. Personally, I kind of just feel like, if that's helping somebody and it's helping them to recover or helping them in terms of having, a positive attitude towards their recovery process, then that's wonderful. I guess from a clinical standpoint, the extent to which that has validity, right? That, that's another question. So it seems like there's two domains. One is the personal, where you're encouraging people to obviously improve their well-being and quality of life. And if that helps them, then that's wonderful. And from an empirical basis, it seems like, the extent to which they would be treated as somebody in recovery, from like if they're in a study is another question, right? And so, yeah. So I think that's just a kind of one of those things that it's the different domains. But yeah, I could see that that's something that's hard to think about, right? Or hard to conceptualize in those two areas. But that's, yeah, it's a very good comment.
I think your research conceptualizes it nicely and operationalizes it. And so we have a question from the great Katie Wickowitz. So Dr. Wickowitz says, "Great talk, Kevin. I'm wondering if you've considered expanding the recovery identity work to developing interventions and to examine recovery definitions for gambling disorder." So 2 questions.
Oh, yeah. Oh, that's a great point. Yeah, that's Dr. Wickowitz, thank you so much for that question. Yeah, I mean, I'm really trying to figure out the best way to tackle that, and working with Dr. Kristen Lindgren, who's developed identity-based interventions, and trying to figure out like how can we tailor those interventions with respect to alcohol recovery. And I think that's such an amazing work. And I'm definitely interested in that and segueing what I'm currently doing to working on that in future grant applications. And I think that's definitely needed. And I think, one of the issues was that some of those interventions that were previously conducted were among like college students who weren't really, heavy drinkers or, clinically relevant in terms of being, maybe being diagnosed with alcohol use disorder. And so maybe some of these identity-based interventions may be effective with more clinical populations. So definitely looking towards opportunities to develop identity-based interventions to help individuals during this recovery process. I think that's so important. And that second component of looking at recovery definitions for gambling disorders, yes, absolutely. Like, just that's something that I would love to do. And focus on that and really transitioning what I've done in this kind of alcohol space and looking and talking about it more with respect to gambling. I think that's necessary and it's important, especially with the increased push to legalize online gambling in the United States, and it looks like we're moving towards that. I think that's important to kind of start talking about potentially more individuals who might have a gambling disorder and ways in which we can help them through that process. So yeah, that's the very, very, obviously really good questions. Thank you, Dr. Wickwitz.
Yeah, and great comments in response, Kevin. And it is interesting. I haven't really stayed up on regulations for gambling, and I didn't know about that. But like one of the things that we often think about, right, when addictions and recovery is that alcohol is all around you. And then we used to historically think that gambling, it's like, you had to go to the casino and, it's, there's certainly high risk situations for that could interfere with your recovery, but different than, just going out to a simple restaurant, and facing that on a weekly basis. But kind of as you are alluding to, as online world changes and gambling becomes much more accessible, it's a lot, there's going to be a lot of parallels there. So that this idea of, recovery identity could be really, really important for folks who kind of are going to have to be vigilant on a daily basis, potentially for gambling. So I think you should submit that grant.
Yeah, thanks. Yeah, no, I definitely plan on doing that. Yeah.
Great. Okay, so Dr. Noel Vest from Stanford, he asked, how are you measuring quality of life? And I'm also interested in your thoughts on recovery capital and how that may play into your modeling, which I think maybe, go ahead.
Yeah. In terms of quality of life, I got to look more into that in terms of recalling of how we assess that. But, in looking at the definition, it's just, the extent to which, one is happy with one's life, just broadly speaking. And how that may, and then so the other question is also interested in your thoughts on recovery capital and how that may play into your modeling. That's a good question. I in terms of recovery capital, I haven't really looked at that concept, again, being in kind of the experimental space to really speak, on that topic. But I imagine that it would play a role in terms of how we model and look at recovery outcomes and the extent to which people are transitioning from having issues and problems with alcohol to kind of being in this kind of recovery space. So I imagine that would play a role, Noel.
So Kevin, I don't know if you know this, but what does recovery capital? How would you define it? Do you know? Yeah. Thanks.
Yeah. I guess it would be kind of like social support, things like of that nature. Things that like, having a friend or family member who is supportive of one being in the recovery process. I imagine that's kind of forming the basis of, what recovery capital kind of is. And I think that's so important that it's, like recovery isn't, done in isolation, like others, individuals, reach out to help, people transition. And in some of the focus group data that I collected, it was really just wonderful to kind of hear individuals kind of lived experiences. This is the first time that I had an opportunity to do that type of work. Usually I do survey data where I kind of collect data, quantitative and qualitative, but not really hearing people's kind of lived experiences, like sitting in the room with them and asking them, like, what do you think about recovery? And then just kind of hearing their stories of like, hey, I was, I know people, who are in recovery, or they might even say, I was in recovery. And, the way that I was able to make it was I had help from family and friends and loved ones, and people reached out and provided just so much support. And it was just really great, kind of great to hear, to kind of contextualize a lot of the research that's done. Again, for the most part, I was doing survey data and like looking at models and analyzing data, but like to actually hear people talk about this kind of experience is just so, it was just, I mean, it was so motivating to just hear that. And not only that, but to just, it was kind of cathartic for them. Like they were kind of, talking about this, and that they actually felt like they were part of this process. And I felt like it made them feel better, especially people who had problems, like, have kind of turned the corner. They're like, wow, like this was wonderful. You should do this, and just, I think people being able to share their experiences and feeling like what they have to share is valuable, not just, on a survey, but actually bringing them in and hearing them, like just hearing what they have to say. I just felt like that was moving, not just for the clinical, population, the individuals who had like previously were like in recovery and are not in recovery now, but are, kind of in sustained recovery, but also college students. I think that's one of the things, like most college students don't really, you would think that, yeah, recovery isn't really relevant to them. But again, like what I was saying before, is that it substance use and misuse impacts everyone in the family. So fathers, you know what I mean? Your grandmother. So it's like everyone probably directly or indirectly has experience with kind of the negative consequences of using substances, right? And so I think that right there is just kind of like, letting people vent and share was just, it's just so moving, and really kind of helped motivate my research in this domain. And it was just kind of wonderful to hear.
Okay, awesome. Well, we're winding down. Maybe I'll ask one question. I'll ask for like a really quick answer.
Okay.
And so, the idea of like identity and, an identity of someone being in recovery, and that, potentially being an important predictor in and of its own right of outcomes. Like, what do you think about the moderators, right? Because I've always thought about that, and I was like, some people like who maybe have like a propensity towards addiction and structure, and or maybe they get, it's almost like it consumes them, and they kind of get, I hate to say this, or maybe I don't, they get addicted to the process of recovery, and so like, and you and I might think about personality traits that as potential have you ever kind of thought about moderators like that?
Yeah, no, that's really interesting in terms of like, I mean, I just think about it like, if for example I had an alcohol use disorder and I was like, okay, tomorrow, I just want to stop drinking, and that kind of propelled my kind of interest in this identity change literature, because my grandmother, like in the 70s, she was a smoker, and she just said she wanted to quit cold turkey, and she did it. And so and everything that she did before would indicate like a 99.99% probability that she was going to smoke the next day. But she made that decision to say, nope, I don't want to smoke. And it's very rare, but it is possible. And I guess to a lesser extent, that's what I was thinking, people probably leverage this identity change. But yeah, in terms of moderators, yeah, definitely, like kind of recovery capital would be one moderator, right? Like if I'm saying I don't want to drink anymore, and I have my friend Mike who's a big drinker and partier, you know what I mean? The extent to which I'm able to like maintain that identity state of being a non-drinker is really contingent upon one's environment, or that other personality traits, like you were saying, of like they get addicted to the process of being in recovery, or like the process of dieting. You see some like people
that's true.
Dieting, and then it becomes this whole other thing where they really just embrace this dieting mentality, and that kind of consumes who they are as a person. And so I guess if anything, it's everything kind of in moderation, right? I guess that we've learned.
Hard for me personally, but
me too.
Yeah, great parallel to the kind of dieting behavior change. Well, thank you, Kevin, Dr. Montes, for the great talk. Congratulations on your outstanding work. And for those interested in our seminar series, hang on the line. We're gonna show, okay, great. So we'll take a little bit of a break in the summer, and then we're honored to have Tamika Zapolsky from IUPUI presenting about her interesting work. So thank you all for attending, and have a wonderful week. Goodbye.